A very good afternoon, one and all. I'm going to present a prospective study on safety of routine hydrodissection in posterior polar cataract with intact PC, imaged using anterior segment OCT. Avoiding hydrodissection in polar cataracts causes difficulty in rotating the nucleus, which is difficult to chop, and also we are left with a dense epinuclear sheet. All these leads to increase in surgical time and manipulation, which again increases the risk of PC dehiscence. And we know that there is a strong scientific literature evidence of anterior segment OCT in the preoperative evaluation of posterior capsule in polar cataracts, and it has a high negative predictive value, which means if the PC is traced intact in the preoperatively, it is unlikely to rupture during cataract surgery. And Titial et al. Has demonstrated the safety of hydrodissection in type 1 PPC imaged using intraoperative OCT, and out of the 19 eyes where the PC was distinct, with hydrodissection, he reported an incidence of PCR to be 0. And they also mentioned that the preoperative AIOS2025 images correlated with the intraoperative OCT image. We know that the talk of hydrodissection in PPC is controversial, but keeping in mind of these two scientific evidence, we designed a study to evaluate the safety of routine hydrodissection in polar cataracts with intact posterior capsule imaged using Swepso's anterior segment OCT. It was a prospective interventional study. Ethics committee approval was obtained, 8 months period, and it was done at Eye Foundation, Coimbatore. Eyes with typical PPC, we did a slit lamp imaging and also did the AIOS2025. And in eyes where the posterior capsule could be traced intact beyond the polar opacity were grouped with intact PC, and we did a gentle hydrodissection and nuclear rotation. And in eyes where the posterior capsule was not clearly delineated beyond the polar opacity were grouped as PC with discontinuous PC, and we did hydro delineation and the nucleus was not rotated. Group 3 PPC was very uncommon, where the PC was open with outpouching of the lens matter in the patella fossa. We had only one eye and we excluded this from our study. In eyes where, in group 1 eyes, after making a clear corneal incision and a rhexis of adequate size of 5 mm, we did gentle hydrodissection using a 27 gauge cannula. The balanced salt solution is injected gently but slowly, and we observe the fluid wave to pass across the polar opacity, and once this is done, we gently decompress the nucleus and rotate it. The nucleotomy technique varied between direct chop and stop and chop. Routine phacoemulsification parameters were used. As cataract surgeons, we are always used to rotate the nucleus and keep the nucleus in the opposite quadrant of opposite side of the clear corneal incision for better chopping. And doing a gentle hydrodissection and nuclear rotation helps us to manage the nucleus more efficiently and safely. And also you can see that at the end of phacoemulsification, the epinucleus comes along with the nucleus, and there is no need to deal the dense epinucleus plate. All we have to do is remove the cortex and place the IOL of choice. In cases in the flax, we did not increase the posterior offset, and we did very gentle hydrodissection, keeping in mind the nemodissection that would have already happened. In group 2 PPC, after hydrodissection, only hydro delineation was done, and after golden ring, we removed the epinucleus and lifted the endonucleus and emulsified it, and the epinucleus plate was visco-dissected and then removed, and the IOL was placed. In the flax group, we increased the posterior offset to 800 microns. So the outcome measure was to just assess the PCR rate in the two groups. Most commonly seen posterior polar cataract is type 1 with 54 eyes and 76%, and we had 1 eye of PCR in group 1, whereas 4 in group 2, and this was statistically significant. When we analyzed the video and the AIOS2025 of this rent patient in group 1, the AIOS2025 PC was intact, but this was one of the first case of the surgeons, and the hydro was little forceful, and it resulted in a capsule blowout after hydrodissection. So hence care should be taken to avoid hydrodissection, and all other precautions of maintaining the AC, everything has to be followed. The negative predictive value of the SS-based anterior segment OCT with gentle hydrodissection is 98.1%, and the positive predictive value of 25%, which means that if the PC is discontinuous, not all, it implies that it is dehiscent. It could be because of the dense polar opacity, which has not let the scan to penetrate and visualize the posterior capsule. Few studies has been documented in the literature regarding the hydrodissection, and these studies, they have not done anterior segment OCT in the preoperative period. And one study by Asia et al., it was a retrospective study of 10 eyes where he has done flax and reported no PCR. And this was the study by Titial et al., which I have alluded to. And we have used AIOS2025 to prick the low risk variant, and we have performed a gentle hydrodissection. The strength of a study is a prospective study and its large sample size. And the limitation, we had very less eyes in the flax group, so we could not compare. And 5 experienced surgeons were involved, so there could be interpersonal surgeons variability. So to conclude, gentle hydrodissection and nuclear rotation could be done in this low risk variant of PPC guided by anterior segment OCT for efficient nucleus and epinucleus management. Care should be taken to avoid overzealous hydrodissection. Thank you.
So ma'am, do you think like if this study would have been by a single surgeon, would the outcome would have been different?
Actually, no. Actually, if you are going to take one single experienced surgeon, then we can attribute the success of the surgery to that experienced surgeon. Here we have 5 different surgeons, one with 30 to 40 years of experience, another with 20, another with 10.
So how will you compare the results then? Because if the experience of surgeon is different.
No, that's what. In the type 1 PPC, only one case had a PCR. That was the first case, and all other cases which was done, distributed all across, we didn't have any PC dehiscence in the type 1.
Other than that, have you noticed any PCR like happening after, like we are doing when we're closing the eye or when we put the
we
lens?
followed all other precautions like maintaining the anterior chamber, not polishing the posterior capsule, not overhydrating. All others were followed. Only variable which we deferred was only doing a gentle hydrodissection and nuclear rotation if the PC was intact in the pre-op imaging. All other precautions were followed. Yeah.
Thank you. Okay, thank you.
Thank you so much. A nice